My colleagues, Phil Shower, Scott Cahan, and myself are very thankful to Mayo Clinic Proceedings for giving us the opportunity to share with you some ideas on how to take care of patients with severe obesity. Class 3 severe obesity, BMI or body mass index over 40, has the highest increase in prevalence and also plays a tremendous role in increasing morbidity, mortality, and healthcare costs. Obesity is associated with numerous diseases. A small amount of weight gain increases the risk of developing type 2 diabetes, hypertension, and hyperlipidemia, among other conditions. Individuals with BMI over 55 have a reduced life expectancy, and the cost of severe obesity accounts for 35% of the total costs of obesity care. Bariatric surgery is currently the most effective treatment for most patients with severe obesity. However, whereas more than 60 million Americans fit the indications for bariatric surgery, only 200,000 patients per year undergo surgery. What are we to do for the other 99% of patients with untreated severe obesity? That's the question that our paper tries to address. We currently lack of a scientifically based, systematically interdisciplinary approach to addressing severe obesity. Consequently, patients with severe obesity are typically treated for their comorbidities, and a paradigm change is necessary, in which we treat the obesity rather than the continued treatment of complications. So please let me review with you some of the steps that healthcare providers could consider to help their patients who suffer severe obesity. First, we need to address underlying contributors. We need to identify any physiologic, psychological, or iatrogenic factor contributing to weight gain. We need to perform a detailed history, including data related to nutrition, physical activity, weight history, weight-related contributing factors, comorbidities, and risk factors. Medications to treat psychiatric disorders, type 2 diabetes, hypertension, or osteoarthritis usually cause weight gain. A special effort should be made to review these medications. Number 2, maximize our visit time. Patients with severe obesity need to receive a weight-centered approach to treat this condition. An interdisciplinary approach involving nutrition, physical activity, appetite control, optimization of sleeping habits, and evaluation of potential depression, anxiety, or eating disorders should be clearly outlined. Treatment has to be personalized and should consider the use of online questionnaires to obtain a detailed medical history and a review of systems. Patients need to be seen frequently, usually once a month, to monitor progress, and the use of shared medical appointments, e-coaching, and virtual visits has been very well received by our patients. If after 3 or 6 months patients are not responding appropriately, a referral should be considered for bariatric surgery. Number 3, rethink outcome expectations. Losing enough weight to get to a BMI of 25 or less than 25 in a patient who is more than 100 pounds overweight is in many cases unrealistic. We need to keep in mind that at least a 3% weight loss improves glycemic control, and a 7% weight loss decreases the risk for type 2 diabetes by 60% in patients with prediabetes. Number 4, provide or refer for intensive behavioral therapy. Behavioral therapy in patients with obesity and type 2 diabetes has shown improvement in numerous cardiovascular risk factors, quality of life, hospitalizations, and healthcare costs. Intensive behavioral therapy is endorsed by the US Preventive Service Task Force and now covered by Medicare. Number 5, combine counseling with pharmacotherapy. Pharmacotherapy plus counseling for obesity leads to nearly double the weight loss or either alone. In patients with BMI over 30, FDA-approved anti-obesity medications, including orlistat, lorcaserin, naltrexone, and bupropion XR, phentermine plus topiramate ER, and liraglutide lead to 5 or even 15% weight loss in patients who have completed at least 1 year of treatment. There are several studies documenting that. Number 6, decrease barriers to and stigma against bariatric surgery. Increased knowledge about our healthcare providers and patients alike should lead to a more informed discussion and consideration of bariatric surgery rather than emotional or ideological reactions for or against surgery. Perioperative safety after bariatric surgery is similar to other abdominal laparoscopic surgeries, and long-term efficacy is well established with improvement or resolution in numerous weight-related comorbid conditions and reduced mortality. Number 7, pay attention to biased beliefs about patients with severe obesity. We cannot help all patients to lose weight, but we can treat all patients with the same respect and compassion that we extend to all other patients, which will, at a minimum, likely improve quality of life. I hope the steps articulated herein can help our patients with severe obesity to meaningfully address their weight and health. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.